Hello, everyone. I'm Doug Cushman, the president of the Case Management Society of New England, and I'd like to thank you for joining us for this presentation, Identifying and Managing Signs and Symptoms of Cervical and Lumbar Disc Herniation. Our program tonight is presented by Dr. Christian Klare, who practices with the New Hampshire Orthopaedics. First, I'd like to introduce Karen Mackey. Any of you who've been involved with our organization over the years are familiar with Karen. She is a longtime CMSNE supporter and founder of the New Hampshire extension. Karen is the clinical director of New Hampshire Orthopedic Center and would like to speak to you for a few minutes about their practice. Go ahead, Karen.
Thank you very much for the opportunity to take this CMSNE to the next level and looking at Zoom and other methods of education in a time that's a little bit difficult for all of us. New Hampshire Orthopedic Center has been in practice for many years in the southern portion of New Hampshire. We have 5 offices and we have many disciplines that we specialize. We have general orthopedics, hands, foot, spine, and we have been practicing in the area and do surgery at all 5 hospitals in the southern portion of the state. So I thank you for this opportunity. I'm going to move my chair and get Christian over here so that he can start the presentation.
And I'll introduce Dr. Klare to you. Dr. Klare specializes in orthopedic spinal surgery. He graduated summa cum laude from, with a degree in biochemistry from UNH. He earned his medical degree from Jefferson Medical College in Philadelphia, graduating magna cum laude. He completed his orthopedic surgery residency at Dartmouth Hitchcock Medical Center and his spine surgery fellowship at Ortho Carolina. He is a member of the American Orthopedics Association Emerging Leaders Program and the North American Spine Society. Dr. Klare has served as a research assistant at the University of New Hampshire and Jefferson Medical College and Rothman Institute. His primary area of focus is postoperative neurological complications following shoulder surgery. While at Ortho Carolina, he participated in a number of lumbar spine research projects. He has published and presented in a variety of topics such as master techniques in orthopedic spinal surgery, lumbar disc herniation, atypical femoral fractures, and total knee arthroplasty. Dr. Klare is an outdoorsman who enjoys skiing, mountain biking, and camping, as well as woodworking. Please welcome Dr. Klare with me. Thank you for being with us tonight.
Thanks for that introduction, Doug. This is my first Zoom presentation, so bear with me if it's a little awkward, but I think we'll get through it together. So tonight we're going to talk about the evaluation and management of lumbar and cervical spine disc herniations, and my name is Christian Klare, as Doug mentioned. So I have no relevant financial disclosures. The objectives tonight, we're going to talk about the signs and symptoms of both cervical and lumbar disc herniations. We'll identify red flag symptoms that should prompt more urgent referrals. We'll discuss the importance of initial workup, and then we'll outline appropriate initial treatment techniques and when you need to refer and what happens when you send those patients for further referrals. So just a brief general overview of spine terminology. These are things that you'll see on MRI reports or office notes. They look big and scary, but they really kind of all mean about the same thing. So spondylosis is just degenerative process. So that just means arthritis anytime you see that word. Spondylolysis, that's when there's an actual defect in the bone. It's like a little fracture in the bone. You can see that on X-ray or MRI. Stenosis is just when you have narrowing of the canal or the foramen. And how I describe this to patients is that normally in the lumbar spine, we have nerve roots. And normally those nerve roots, when you look at them, they float in the spinal fluid like spaghetti floating in water. So stenosis is just when those nerve roots get pinched. Spondylolisthesis, that's when one vertebrae actually shifts forward on the one below it. Spondyloptosis is when it does that so much that they completely dislocate. Radiculopathy, these are symptoms like pain, numbness, burning, weakness in a certain distribution, and that's caused by compression or irritation of the nerve, and that can be from arthritic changes, it can be from a big disc herniation. And then the last thing is myelopathy. And myelopathy is just a disease of the spinal cord. There's no spinal cord in the lumbar spine, so this happens in either the cervical or the thoracic spine. And when this happens, it usually presents as a progressive, gradual deterioration in neurologic functions. Patients typically note that they're doing well, and all of a sudden they notice that they need a cane to get around because they're tripping, falling more often. Then they notice that their handwriting has changed and they can't do buttons or zippers anymore. It's this progressive decline that over time patients will end up in a wheelchair. So it's important to identify early, because the treatment for it never gets you back to where you were. The treatment for it is to prevent you from getting any worse. So that's something important to always have in the back of your mind. So we'll start with lumbar disc herniations. So the lumbar spine has 5 vertebral bodies, and then that joins up with the sacrum, which is S1. Let's see, I'm not sure if you guys can see my arrow, but basically the vertebral body and the disc make up the anterior part. Posteriorly, we have the lamina, and then we have the pedicles, which join the front to the back. And within is the spinal canal, where all the nerve roots traverse down the lumbar spine. As they traverse down, they exit through the foramen, which is the little nerve tunnel. And the foramen is made up of the disc in the front, the pedicle up top, the pedicle below, and then the joint. So you can see how close that joint is here, and that disc is there. So you can imagine if you get disc bulging, or if you get arthritis in this joint leading to bone spurs, it can put pressure on those nerve roots, and that can cause a radiculopathy or radiculitis. So this is, again, a cross-section showing that same thing. So the disc is made up of kind of 2 layers. It's kind of like a jelly donut. It's made of this thick annulus fibrosus, which is a thick ligament that goes around the outside. It's circular. Then on the inside, you have a hydrated gel called the nucleus pulposus. And disc herniation usually happens when you have degeneration of a disc that makes the annulus more brittle, and that can lead to little cracks or fissures in it, which allow the nucleus pulposus to exit through into the spinal canal, where it puts pressure on the nerve roots. So these are 2 cross sections of cadaveric specimens. On one side, you see a nice, normal, healthy disc. This part in the middle that looks like a little jelly, that's the nucleus pulposus. Then you have the thick outer layer, the annulus fibrosus, which connects it to the end plates. As you get older, it degenerates. That nice, healthy, hydrated gel starts to dehydrate. It gets brittle, it cracks, it shrinks. And it can even get to the point where the disc completely wears away, and that's when you hear people say that they have bone-on-bone arthritis. On the right side, you can see the nerve roots coming down, and you can see how this disc is bulging with a bone spur, and it actually puts pressure on the spinal canal right there. This is another comparison between a very, very young spine. This is probably a child cross-section. You can see how big those discs are. And then as you get older, those discs collapse and they bulge and you get bone spurs. And this is a good example of that word we were saying earlier, spondylolisthesis. So down below is S1, this is L5, this is L4. The front of L4 is here, the front of L5 is there. So you can see how L4 is actually shifted forward. If you think of the spinal canal like a bunch of napkin rings lined up, if one moves forward, that space where the nerve roots are going decreases, and it can lead to kinking and pinching of the nerves, which can cause pain going into the legs. This is a histologic slide or illustration of a cross-section. So it would be 1 vertebral body up top, 1 vertebral body down low. You have the nucleus, which is the inner part, and the posterior aspect is this very thick ligament called the posterior longitudinal ligament, and that inserts onto the disc and inserts onto the cartilaginous end plates. And as that comes down, it fans out into this triangular pattern. Problem is, you can see that there's these little bare areas that the disc is not covered by the posterior longitudinal ligament. These are the most common areas where you get disc herniations, called paracentral disc herniation. So this is if you're looking from someone's back, this is what it would look like. So on the left, there's a illustration of a healthy disc with a corresponding MRI. On this image, this is a T2 axial image, so fluid shows up bright white. So all this is the spinal fluid, and like I said, it's the spinal fluid, the nerve roots. It's like spaghetti floating in water. Each one of these little dots is the nerve root that's working its way from the spinal canal out to form the nerves that make up the bigger nerves that go to the legs. So the nerves exit through the neural foramen, which are those tunnels, and then they don't just make a 90-degree turn. They don't come down the spine and leave. It's more of like getting on or getting off of an off-ramp. So it's a gradual kind of process where they exit through the spine, and we'll talk about that a little bit more in detail. This is another cross-section of a nice, normal, healthy disc. You can see plenty of spinal fluid. You can see all the little nerve roots. They have plenty of room. They're not bunched up or clumped together. In the lumbar spine, there's an order to the anatomy. So the L4 pedicle has the L4 nerve root going underneath it, and then underneath that is the L4-5 disc. So the order is always pedicle, nerve, disc, pedicle, nerve, disc. This is important because if a patient has a paracentral L4-5 disc herniation, the L4 nerve root has already exited the spine, so it's not going to injure the L4 nerve root. It injures the L5 nerve root because that is the one that's getting on that off-ramp and is gradually getting to its pedicle. So it's important to know exactly what type of disc herniation you're dealing with because it's going to affect a different type of nerve root. If you get a disc herniation out in the foramen, that's where it's going to pinch that same level. So paracentral disc herniation at L4-5 gets the L5 nerve root. Foraminal or extraforaminal disc herniation L4-5 gets the L4 nerve root. Each nerve root goes somewhere particular, and this isn't something that's 100%. Nerves don't read the textbooks, but typically the L4 nerve root, we test that with the patellar reflex, and we have the patient's dorsiflex, which is the tibialis anterior. It usually does sensory loss, numbness, or pain in the distribution of the big toe or the medial malleolus. There's no reflex for L5, but we test the EHL, or great toe dorsiflexion. It goes to the dorsum of the foot. Usually patients will say that starts in the buttocks, goes down the posterior leg, then starts to wrap around almost like a shin splint and will go into the top of their foot. And then S1 is the typical sciatica that patients talk about. Goes straight down the back of the leg into the sole of the foot or the lateral heel. And that's associated with the Achilles and the gastroc-soleus complex. So these are the kind of main types of disc herniations that we see. Remember, we talked about the posterior longitudinal ligament having those thin bands. So that's when you get a median or a paramedian, which is all the way on the left. You can get a disc herniation into the foramen, or you can get a disc herniation outside of the foramen, and the nerve root can get pinched at any one of those locations. The reason why this can be an issue is if you look at the nerve, you can see how it gets really bulbous as it exits the spine. And that's called the dorsal root ganglion, and that's where all the cell bodies live. So that's where all the proteins are being synthesized, all the waste products are being utilized in different ways. That's where all the proteins are being transported from. So when you get a disc herniation, like a far lateral disc herniation or a foraminal disc herniation, it puts pressure on that dorsal root ganglion, and you can actually get cell body death, which leads to persistent symptoms. Patients usually also have more intense symptoms. They're usually discussing a searing or a burning type pain, where other patients say it's a shooting or electrical type pain. It's typically more severe, and patients typically don't do as well with surgery as the central or the paracentral types. So this is a cross-section schematic and another axial T2 MRI showing a central disc herniation. Central disc herniations usually cause primarily back pain because they're just going in the center. They're not pinching those nerve roots in the lateral recesses. This can become a problem if they are very large. If you have a very large central disc herniation that completely obliterates the canal and puts pressure on all of the nerve roots, then you can get something called cauda equina syndrome, which presents with leg weakness, numbness, loss of bowel or bladder control, which is a surgical emergency. That's something that typically, goes either in the middle of the night or first thing in the morning. We take them to the OR. This is the most common, which is a paracentral or posterolateral. And I'm going to point to this MRI, which is another T2. You can see all the bright spinal fluid. This red circle is, so this is the L4-5 disc. So this is the L5 nerve root as it's getting ready to get under the pedicle. It's traversing across. You get a disc herniation, and it pinches that nerve up against the facet joint. And when that happens, it leads to inflammation and irritation of the nerve, and that causes that pain signal to go down the legs. It can also cause weakness, numbness, tingling in that same distribution. And then this was the third type that we had talked about, the foraminal, and you can see how that's impacting the dorsal root ganglion here, that bulbous part. And you can see a good example of that out here. It's outside of the foramen. So if you read MRIs of the lumbar spine, you'll see words like protrusion, extrusion, or sequestration. Protrusion is basically just when you have a bulging of the disc. It doesn't mean that you have an actual herniation where there's an actual tear in the ligament. It means that things are just generally, bulging. Extrusion, when you actually have herniation of the disc material through the annulus, but it remains in contact with the inner nucleus. Once that breaks free, then we call it a sequestered fragment. And studies have shown that the size and shape of an MRI, or the size and shape of the disc herniation on MRI, is the most predictive factor when it comes to patients getting better when compared to things like workers' comp status, age, sex. The reason why is maybe coming up, but so on this, you can see when you have degeneration, you just get some bulging. Prolapse is a little bit bigger of a bulge. Extrusions, when you actually have a tear in the ligament, but it remains contiguous with the inner nucleus. And with the sequestration, that's when you actually have free fragments in the spinal canal. And the body sees big disc herniations like this or sequestered fragments as a foreign object. So it will make a new blood supply to this area and have special cells called phagocytes that come in and basically gobble up that disc herniation. And over time, you can get resolution of the symptoms because there's no longer pressure on the nerve roots. So it's a 2% prevalence, usually presents in the 4th through 6th decade. It is usually a period of an acute back pain, which we think is an injury to the annulus, that thick ligament. This is an MRI showing signal in the annulus. So again, fluid on a T2 is bright white, so spinal fluid. But you can see it within this black, which is the annulus, you can see an area of bright white, which means that there's tear, there's an edema present in that annulus. So usually patients will say that something happened, they had an acute onset of back pain, and we think that's because the annulus is torn. Now there's that opening where the nucleus can get through and put pressure on the nerve roots, and that's when they start to complain about leg pain or weakness or numbness. But I see patients, 2 or 3 weeks in, I always tell them, listen, the good news is 90%, 95% of these patients will get better without any type of surgical intervention. It's just a matter of keeping them comfortable while the body heals itself. So again, going quickly through this, we talked about the central prolapse. This is usually just a localized back pain. If it's like L5-S1, it's down towards the bottom. If it's L1, L2, it's a higher up low back pain. But it can be associated with the cauda equina syndrome if it's a large disc herniation that puts pressure on the nerves that go to the bowel and the bladder. Paracentral is the most common. Fortunately, we see these 90-95% of the time. It's where the PLL is weakest and affects the lower nerve roots. So again, paracentral L4-5 disc herniation. The L4 nerve root has already left. The L5 nerve root is making its way down. That's the one that gets pinched. And then the foraminal far lateral, that affects the dorsal root ganglion. I had a attending in fellowship say that the most important part of adult learning is repetition. So I'll repeat things a couple times throughout this. This is an MRI showing a foraminal disc herniation. So on the left, as we start at the top and work our way down, you can see the foramen, and then inside you see the white, and this is a T1, so you see fat on the T1 is bright white, and then you can see this black circle here. So that black circle is the nerve root, so we like to see a lot of fat around it because the fat acts as the cushion. So as we work our way down, we can see this nerve root with a lot of fat, this nerve root with a lot of fat, and then when you get down here, you can't see the nerve root, you can't see the fat, so that means that there's been a disc herniation. We can see that better on the axials where it's actually outside the foramen putting pressure on the nerve. This is a very cool before and after MRI. So this is a patient who was treated non-operatively. So this is a large L4-5 disc extrusion or sequestration. And you can see after a few months with non-operative management that the body completely resorbed it. So that was without surgery. This is another example of that. So again, large L4-5 disc. You can see how much stenosis it is causing. It's almost completely obliterating the canal, but without any type of treatment, it goes back to almost normal. A little bit decreased disc height compared to the others, but overall successful if you stay out of the operating room. So again, the main symptoms, again, key to adult learning is repetition. So axial back pain, this could be discogenic, which is when the disc starts to dehydrate and gets brittle. There's a lot of pain fibers that innervate the disc. Or it can be mechanical. The facet joints in the back, those are the ones that let you bend forwards and backwards and side to side. Those are like knee joints, hip joints, wrists. They have cartilage on it that can wear away, and over time you can get pain from those joints, usually when you're putting pressure on them, so standing and walking or doing high impact activities. Radicular pain, again, that's the buttock and the leg pain. It's worse with things that increase the intra-abdominal pressure, so coughing, valsalva, sneezing. When you increase the intra-abdominal pressure, it causes that disc to push out a little bit more and get those nerve roots. So patients will say, yeah, I'll finally get comfortable, and then all of a sudden I'll cough or I'll sneeze, and then I'll get that zing right down my leg. And that's because there's more pressure coming from the abdomen, putting pressure on those discs. Other red flag symptoms, bilateral leg pain or weakness, saddle anesthesia, so that's numbness on the inner part of the legs or in the groin. And then bowel or bladder symptoms. And if you get a patient who says that they are having bowel or bladder symptoms, you don't just leave it at that, because maybe the patient's just started taking a laxative and now they're having diarrhea. Those aren't the bowel or bladder changes that we're interested in. We're interested in the patient is just walking around, they can't even feel their bladder getting full, and then all of a sudden they just start wetting themselves. And when they go to clean themselves up, they can't feel it because their genitals are completely numb. So it's important to kind of find that distinction. And the other thing that is very common is patients will have so much pain that they can't get up and they'll be wetting themselves. So if a patient does say that they have had incontinence, it's important to know, is it because they just didn't know their bladder was getting full, or is it because they're having so much pain that they couldn't get to the bathroom in time? And that's often the case, because cauda equina is only about 1 to 10%, and I think it's closer to that 1%. The red flag symptoms, so these are things where you stop, you really have to start thinking about it. You have to start thinking about ordering MRIs and urgent referrals. So back pain with fevers, chills, night sweats, that's worrisome for infection, worrisome for tumor. Bowel or bladder incontinence is the big thing. That's you do not pass go, you go right to the ER for that. Saddle anesthesia is the same, and then it's important to take a good history. So a patient who uses heroin or whatever other IV drugs that they're using nowadays, or someone who's immunocompromised, someone who had a liver transplant on chronic immunosuppression, those patients are set up for an infection. And epidural abscesses can be a big problem if they go untreated. you get a patient who's an intravenous drug user, they come and they start complaining of back pain. So, you know, the primary care doctor or urgent care doctor prescribes them Medrol dose pack and, you know, some NSAIDs and sends them out the door. Then they come back a couple days later, they're still having back pain, so they get some narcotics. Then they come back and it's getting worse. I've actually seen epidural abscesses go all the way from the cervical spine all the way down to the lumbar spine. And that becomes an extremely big problem because if it spreads to the cervical spine, it can put pressure on the spinal cord and lead to paralysis. So again, these are red flag things that you're going to want to send patients to the ER or get an urgent referral for things like this. So taking history is obviously the first step, physical exam and imaging. I usually start with motor and sensory exams. So I check all those muscles we talked about in the beginning, the dorsiflexion of the foot, dorsiflexion of the great toe, gastrocsoleus complex. So I make them toe walk, I make them heel walk. And then I check sensation. I compare them to both sides and I say, does it feel the same or different? And if there's difference, I kind of note which dermatome it is. Is it going to the inner part of the ankle, the top of the foot, the bottom of the foot, exactly where it's going. They're provocative tests. So remember, when you have that disc herniation, the disc is pinching the nerve against the bone. So normally those nerve roots are able to float free, and as you move your leg, there's some give, they can stretch. But when they're being pinched in the spine, if you straighten out the leg, it's putting pressure on a nerve that can't go anywhere. So a patient who has a positive straight leg raise, if they're sitting down and you have them straighten it out, they'll stop somewhere short of 90 degrees. And they'll say, yeah, it's starting to go down my leg. And if you lift them up a little bit more, they have even more pain. And then if you dorsiflex the foot, which really stretches it, they'll note that they get that pain that shoots down and recreates it for them. Sometimes it can be so bad that it even happens if you straighten out the contralateral side, which is more specific, but it's a less sensitive test. And then I said I make patients toe and heel walk, and I also watch their gait. If I can, I watch them being roomed. Because when you watch them being roomed, you can watch them down the whole hallway. And if you notice that Trendelenburg gait, which you see in a lot of patients with, old hip replacements, that can actually be caused by a pinching of the L5 nerve because the gluteus medius muscle is innervated by L5. So that's an important thing to pick up on also. Normally, when a patient comes in for their initial evaluation, I get just x-rays. And if symptoms persist or if there's a progressive neurologic deficit, then that's when I move forward with an MRI without contrast. And it sometimes it becomes a, not an argument, but a teaching point for patients who come in and, they're having pain and they automatically want to get an MRI. And I've kind of talked a couple people out of it, and I've seen them back 6 weeks later. And they're like, yeah, all my pain's gone. And I said, I know, this is why we don't get the MRI, because even if you showed up with an MRI that showed a big disc herniation, you're still not going to do anything for 6 weeks if, you're just having pain. 95% of the time, they'll get better on their own. So the question when ordering an MRI is always, you order with or without contrast. So I order contrast when I'm suspicious for a recurrent disc herniation. The contrast can show us if something is a recurrent disc because the disc is avascular versus scar. So normally on an MRI, those would just show up as black. But with contrast, scar actually has blood vessels in it, so that will light up. So it will tell us, does the patient have a recurrent disc herniation, which would be amenable to another surgery, or is it just scar tissue? Because it never really makes sense to operate on a patient who has scar tissue from a surgery, and then you're going to do another surgery to take scar tissue out, and it's just going to make more scar tissue. So that's an important distinction to make for a surgeon. Also, infection and tumor are the other 2 times where I'd order contrast with and without. So again, 90-95% improve with non-operative management, which is the first-line treatment. And this includes physical therapy, extension-based exercises, so usually a McKenzie program. The reason why we use these extension programs was actually a kind of a mishap. McKenzie was a physical therapist in New Zealand or Australia, somewhere down there, and he always started evaluating the patients in the prone position, so they'd be slightly extended, and it was thought that that extension was bad, so they'd never leave them in there. But he got distracted talking to someone about some other patient, and he realized he left the patient in the prone position. He came back 30 minutes later, and the patient was feeling better, so he started evaluating it more, and that's how we have this whole McKenzie-based program. NSAIDs, I typically prefer things that are dosed twice a day or once daily, so meloxicam daily, or diclofenac, or Aleve, naproxen. Just in terms of patient compliance, I feel like if you give a patient any more than twice a day, they're not going to remember to take it on a scheduled basis. Muscle relaxers can be very helpful. So with disc herniations, motion becomes painful. The body's natural response to that is to try to prevent the motion. And the only way it can do that is by making the muscle spasm. So the muscles on the side of the spine are very thick. And the thicker a muscle is, the more it hurts when it spasms. So that's why when your big toe spasms, it doesn't hurt as much as when you get a big Charlie horse. So back spasms can be very painful, and that can contribute a lot to the symptoms patients have. So muscle relaxers can be very helpful. I found that Flexeril is typically the most sedating, or the one that causes the most loopiness. Because I have a lot of patients in the hospital getting narcotics, I don't like that combination. So I typically will use tizanidine, where it can still make people drowsy, but I don't feel like it makes them as loopy. In really old patients, I'll use Robaxin, because I think that's even less sedating than tizanidine. I think oral steroid tapers definitely play a big part in my practice. And especially if someone is, young and healthy, I'll offer that to them as kind of a first line, like start with the oral steroid taper. Once you finish that, we'll start you on an NSAID. And I like that because it kind of ramps it up, it gets them feeling better, and it lets them start participating more in physical therapy. I feel like if you don't really get the patient some relief, they're really hesitant to start physical therapy. So if you can get them feeling a little bit better, you can get them more involved, you can get them participating more. So I always say we start with things that are least invasive before going to most invasive. So least invasive, we just mentioned. The next most invasive would be injections. And these can be epidural steroid injections or a selective nerve root block, where you specifically target that nerve that's being pinched. Whenever I talk about injections, patients always ask me two questions. Is it going to work? And if it works, how long is it going to work? And I always tell them I don't know. I don't know the answer to either one of those. About 50% of patients will get better, 50% won't. And those who get better, I've seen patients get better for 2 hours, 2 days. I saw a patient in clinic last week who got an epidural steroid injection, and then he came back 20 years later. So you see the whole gamut. 20 years, 2 hours, there's no way. I cannot predict it. I've seen patients that I've ordered epidural steroid injections, saw them back on my schedule, and I was like, okay, we'll be talking about surgery today. And I walk in the room and they're smiling because they don't have any pain. So I haven't figured out how to predict that yet. I'm not sure anyone really has. And again, those extruded discs are more amenable to non-operative treatment, just because the body does see it as a foreign object because it's broken that annulus, as opposed to protrusions or disc bulges where you still have that annulus intact and you don't have that kind of foreign object reaction that occurs. So my indications for going to the OR are persistent disabling pain going on longer than 6 weeks. You failed non-operative measures. Sometimes we have certain lingo. We call things like a hot disc. Sometimes you get a hot disc, which is a patient who has a bad disc herniation that, they show up to the ER every single day getting Toradol or Decadron injections. It's not getting better. You get them set up. They get an epidural steroid. They just can't function. We call that a hot disc, and sometimes that's appropriate to operate on them sooner than those 6 weeks rather than making them suffer in misery. Again, most patients will get better in those 6 weeks, so we always wait at least 6 weeks before offering someone, the next step, which would be, surgery. And then, like we mentioned in the beginning, cauda equina syndrome, that's a surgical emergency. That's go to the emergency department, and we're talking about surgery immediately. We go right up to the OR. Another indication would be someone who has progressive weakness. So the most common is you see patients who have a foot drop. Once you start to get a foot drop, the chance of things recovering decreases because the bigger the nerve fiber is, the less it likes to be pinched. So that's why patients who get spinal cord injuries in their cervical spine and end up paralyzed typically never get a lot of function back. It's because the spinal cord's a big nerve and doesn't like to be pinched. The next biggest are motor fibers. Smallest are the pain fibers. So those recover fast. Pain usually gets better first. The second thing is numbness, tingling is the second thing to get better. The third thing is weakness, and that's a lot less predictable than pain. The procedure I perform is called a microdiscectomy. I use a operating microscope, which magnifies things up to 20 or 25%, or 25 times, so you can really see a lot of detail with the nerve root and the disc. I do it through a small incision. It's about an inch and a half. Some people do it through tubes. I haven't found that to be as beneficial as some people think it is, but patients do really well with this type of surgery. I always tell patients that spinal surgery is very reliable at getting rid of leg pain. A lot of patients are hesitant to have spine surgery because they've heard horror stories from their friends in the nursing home or their friends at the country club about getting back operations and never doing well. And usually that's because the surgeons were operating not for the right reasons. Usually they're operating for things like back pain. They're doing fusions. Spinal surgery for leg pain is very reliable. It's a lot less reliable at getting rid of back pain. And typically after a microdiscectomy, patients are back to doing pretty much everything by 6 weeks. I operated one former police officer, and I saw him back at his 2-week visit. He's like, yeah, this is a guy who, before surgery, he wasn't doing anything. He lived on, I think it was something like 30 acres. He used to take care of all himself. He ended up having a foot drop. He couldn't walk. And I saw him at his 2-week visit, and he was back walking 11 miles with his dog every day. I saw him at 6 weeks. He was like 100% better. He's working out again, and I just kind of cut him loose at that point. So those are the patients that do really well, and those are the fun ones to take care of. This is the surgery I was mentioning. So we position patients kind of like this. In the operating room, we remove some of the bone from the cephalad vertebrae, some from the caudal vertebrae, and that makes room for us to mobilize the nerve sac and the nerve root in order to get to the disc fragment. We have these special instruments, they're very small, that can work around those nerve roots and work around the nerve sac, and we take out the piece of the disc that has herniated. And that's the most common thing that patients ask is, are you going to take out my whole disc or what? And we always tell them, no, we're just taking out the part that's herniated and is putting pressure on the nerve root. We don't take out the entire disc. So the SPORT trial was a big study done up at Dartmouth. This was a double-blinded study, and it showed that patients who got surgery, had a early increase compared to non-operative patients in terms of reduction in pain. That being said, both groups do get better over time, but the group that got surgery got better faster, and that difference maintained out to 4 and 8 years. I think they may have just published 12-year data recently, but I don't have that in this one. So again, positive predictors, these are things I like to hear. So patient who has leg pain, they're not having back pain. I love that. Positive straight leg raise, weakness that correlates with nerve root impingement seen on MRI. I think the surgeries that are slam dunks are when you have an MRI that shows a disc pinching a nerve that's causing pain in that same dermatome and causing weakness in that same muscle group. When you have everything that lines up together like that, I think that's a really good indication for surgery, and those patients usually do really well. It's when you get in the situation where a patient has back arthritis throughout the entire lumbar spine, then they have some disc bulges here, they have some stenosis here. you're not really sure what you need to do in order to, get them relief. And that's when injections and selective nerve root blocks can help us out. Negative predictors, workers' compensation. Workers' comp patients, they have less relief, less improvement in quality of life with surgical treatment. And then smokers. Smoking and back pain have a definite correlation. Whenever I have a smoker in my clinic, that's one of the things I always talk to them about is if you want to get rid of your back pain, the best thing you can do is lose weight and quit smoking. So we'll shift gears to the cervical spine. So the cervical spine, there's 7 cervical vertebrae, and then you have T1, which is the start of the thoracic vertebrae. Most of the sorry, this thing was just right in my way. So most of the flexion extension, 50% comes from the skull on C1. The other 50% comes through C3 through 7. Same thing with rotation, lateral bend. And then that yes-no motion, the rotation usually comes from C1 on C2. So, 50% or so of motion comes through C3 through C6. The anatomy for the cervical spine, you have the intervertebral disc in the front, which is the shock absorber. You have the uncovertebral joint, which is the lateral overlap of the vertebrae. Then posteriorly, you have the facet joint. And this is just like in the lumbar spine. These facet joints can get overgrown. They can get bone spurs and arthritic changes that put pressure on the nerves. The difference being that the cervical nerve roots go into the arm, so they present with upper extremity symptoms. So we talked about the lumbar spine, that the nerve roots exit under the pedicles. So the L4 nerve root is always under the L4 pedicle. L5 nerve root is always under the L5 pedicle. In the cervical spine, it's different because there's a mismatch. There's 7 cervical vertebrae, but there's 8 cervical nerve roots. So the nerve roots actually exit at the level above. So the C5 nerve root exits above the C5 pedicle, C6 above the C6 pedicle. That continues down until you get to C8. So C8, there is no C8 vertebrae. So C8 exits above T1, and then you start counting down from there. And then it goes back to normal where the nerve root exits under the pedicle. In the cervical spine, there isn't that that difference between far lateral and paracentral. In the cervical spine, a disc herniation at C6-7, doesn't matter if it's foraminal or central, it's going to get the C7 nerve root. So same thing as in the lumbar spine, each nerve root goes to a specific area and controls a specific muscle. So C5 is usually kind of the deltoid area, which also controls that muscle. C6, the way I remember, is a 6-shooter. 6. And that goes to your biceps, wrist extensors. C7 goes to the middle finger, the triceps, wrist flexors. C8 goes to the ulnar digits, and that's the finger flexors. And then T1 is the hand interossei muscles. So yeah, physical exam, a C5 radiculopathy, they'll complain of pain, numbness, tingling over the deltoid, over the lateral upper arm, diminished biceps reflex. C6, they get diminished sensations or paresthesias in the thumb, which can often get confused with the carpal tunnel syndrome. C7 is weakness with their triceps, paresthesias in their index. Sometimes it's going to be on one of the borders of their index or ring finger. And then C8 radiculopathy is when you get paresthesias, weakness in the ulnar fingers, and this can get confused with cubital tunnel syndrome or Guillaume's canal or ulnar issues. All right, so cervical spondylosis, remember spondylosis just means arthritis, degenerative changes. On this x-ray, you can see it. This is C2 with the big long dens that looks like a tooth. So C2, C3, C4. So C4, 5, you can see big bone spurs in the front. C5, 6, another big bone spur. C6, 7, another large bone spur and calcification. You can see that the disc height, which is well preserved in the upper cervical spine, starts to decrease. So this is just an evidence of degenerative changes, arthritis, spondylosis. You can call it any one of those things. So again, you get degeneration of the facet joints, degeneration of the disc, and then those uncovertebral joints. All those things can lead to spurring, facet arthrosis, and those can pinch the nerves that go into the arm, causing those symptoms that we were just mentioning. We evaluate with imaging. We usually start with x-rays at the initial visit. Patients can get a CAT scan. I typically reserve this for preoperative planning if I'm planning to do a motion preserving surgery like a laminoforaminotomy, where I need to know exactly where the bone spurs are in order to plan where my incision, plan where my bony resection is going to be. MRI is kind of the gold standard, what we always use. And the reason why we like the MRI is because it shows us the soft tissues, it shows us the spinal cord, and it can show us if there's cord signal changes. So again, we talked about myelopathy, how it progressively gets worse. One of the changes that we can see when the cord gets pinched is it gets inflamed and edematous. You can see that on MRI. You can't see that on CAT scan. So that's where MRI can be particularly helpful. So starting at the top, these are axial CT scans. So this is the right side, this is the left side. On the left side, you can see the frame, and there's a lot of space between the bones. Here's one of the facet joints. So there's a lot of space for that nerve to exit, versus on the right side, you can see that space is much, much tighter. You can see that again on the next cut right here. You can see how much difference that space is. And that's helpful for me to know exactly how much bone I need to resect in order to get to an inadequate decompression that the nerve root's no longer going to be pinched. This bottom image is a axial or a sagittal CT scan of what's called ossification of the posterior longitudinal ligament, or OPLL. And you can see as that ligament starts to ossify and thicken, it decreases the area for the spinal cord. And that can lead to myelopathy or pinching, which we can see best on the image on the right. You can actually see that bright signal. Remember, T2, fluid shows up bright white. You don't want to see bright white in your spinal cord because that means you have swelling and edema. This was a famous study in 1990 looking at patients who were asymptomatic, putting them in an MRI scanner. And basically, whenever I ordered an MRI, I could count on one hand the number of times I've gotten an MRI report back and it says normal. The radiologist's job is always to look at exactly what's going on, and it's our job to figure out what's clinically relevant. So almost 60% of patients older than 40, the MRI report read that there was, one degenerated or narrowed, level. And one thing that patients commonly will see on their MRI reports, especially if they, print them out at home and bring them in, is if there's a disc bulge. And usually I tell patients that, if I were to go on the street and find 100 people who weren't having any type of back pain, put them in an MRI machine, 60 or so would probably have some sort of disc bulge on MRI. I'm trying to get my angle here. So cervical radiculopathy, when that nerve root gets compressed, it causes pain, burning, tingling, numbness, weakness. And it can get pinched from disc herniations. It can get pinched from arthritic changes. Arthritic changes are typically bony. Disc herniations, soft disc herniations, they both affect the exiting nerve. That's fine. Sorry about that. I just got the operating room, so that was a phone call about that. Special tests in the cervical spine, we'd mentioned all the motor exams, the sensory exams. One special test is a Sperling test, and this is when you have the patient extend their neck, rotate it, and bend it to the side that's affected. And when you're putting a patient in that position, it makes the foramen or that nerve tunnel even smaller. And if it gets smaller and it recreates their symptoms, that's a positive Sperling test. A Lermite sign is when you have a patient who has myelopathy. When they hyperflex their neck, it is basically draping their spinal cord over the vertebral bodies, and that will lead to an electric shock that goes into the arms or legs or radiates down the entire spine. So again, 75%, as you tell them, it's 75–80% of patients will get better without any type of operative management. It's the same thing as the lumbar spine. We start with anti-inflammatories, be that non-steroidal or oral steroids, PT, OT, chiropractic. I typically won't prescribe short courses of narcotics. A lot of studies have shown that patients who get narcotics before surgery, if they end up needing surgery, do worse than those patients who never got narcotics in the first place. So I typically do not prescribe narcotics, and if I do, it's usually just low-dose tramadol. And the rationale that I give patients is one, the study findings, but also the narcotics aren't treating what's causing the pain. Patients are having pain because there's inflammation, there's irritation. So that's why it's important to treat with an anti-inflammatory. Another medicine that can help are the nerve modulating medicines like gabapentin or Lyrica. I always tell patients that these medicines were initially made for patients who are having epilepsy, which is an overactivity of the nerves in the brain. You're having overactivities of nerves in the spine, so over time we've found that these medicines help with this nerve type pain. So gabapentin is also a relatively safe and relatively well tolerated medicine that can be used in patients with radicular symptoms. So there's lots of different ways of treating this if it does come down to operative management. The gold standard is ACDF, anterior cervical decompression fusion. That's when you go in through the front of the neck and you move the esophagus, the trachea off to the side. You're looking right at the front of the vertebra, or right in front of the cervical spine. You cut the disc out with a knife. You have a bunch of special instruments that kind of shave it all down. And then you put in a bone graft shim and then a plate and screws to hold everything in place. That's a fusion type procedure. So the other three that are listed are motion preserving. So you can do the same thing, but instead of putting in a bone graft and plate and screws to fuse it, you can put in a disc replacement. And that's similar to a knee or a hip replacement. It's usually a conjunction of a metal and a polyethylene component that allows continued motion. I have some extras of that coming up. Those are options from the front of the neck, or you can go in through the back. One option would be a lamina foraminotomy, which is when you just shave down a little bit of the lamina, a little bit of the foramen to create room for the nerve root. And then if there was a patient who had disease at a lot of different levels, you could perform what's called a laminoplasty. And that's a lot less common for what we're talking about today. So I'm just going to start there. Laminoplasty is when you go in through the back of the spine. You go through the back of the spine and you're looking at the lamina. One side, you have a high-speed burr, like a dental burr, and you cut through the entire lamina. On the other side, you thin it down to the point where it can crack, and you make a green stick fracture, and then you prop it up with a plate. And then the green stick fracture forms, but it makes more room for the spinal cord and the nerve roots within the spinal canal. Cervical disc arthroplasty is a motion preserving procedure. It's not new, but it's just gaining more acceptance in the U.S. They've been doing it in Europe for 15 plus years. These X-rays are an example of someone who's had what's called a hybrid procedure. So a lot of these devices, when they get their FDA testing and their indications, they were only approved for single level use. So if a patient came in with 2-level disease, initially we weren't allowed to put in disc replacements at 2 contiguous levels. So we would do a disc replacement at 1 level and then a fusion at the 2nd level. The implant I use, the Mobi C, is it's approved for 2 levels, and you can see how much motion that patient had after surgery. And again, if they had a fusion done, those vertebrae wouldn't be moving. And the way you can assess that it's moving is you look at the front of the vertebral bodies, how much closer together they get. But also if you look at the spinous processes in the back. So you can see the spinous process here is touching here, and it's really close to this one. And you can see how much they splay apart when that patient bends their neck forward. So that's a good sign that the patient has a lot of range of motion, because those spinous processes are splaying open with flexion when compared to extension. ACDF is the gold standard. It's been around the longest. It's, you know, tried and true. The one kind of caveat being that when you fuse vertebrae together, it transmits the stress to the levels above and the levels below. And this is true throughout the entire skeleton. So when you fuse someone's ankle, their knee wears out. When you fuse someone's knee, their hip wears out. When you fuse joints, the ones next to it see more stress, and they tend to wear out faster. So patients who are young, if we're able to, that's kind of my indication for doing a disc replacement versus doing a fusion, because the rate at which they wear out and need another surgery is about 3% per year. So if I have a 40-year-old with a disc herniation that's causing them to have arm pain, if I do a fusion, and let's say they're only, let's say they plan on living another, 40 years, 40 times 3 at 120%, they're gonna end up in the operating room at some point with at least one other degenerative level. So in those patients, we try to preserve motion as much as we can. This is another example of an ACDF with a spacer, plate and screws going into the vertebral body. And then lastly, talking about lamina foraminotomy. So this is another posterior approach. So patient is laying face down, you put pins into the head to hold it free during surgery. You make an incision on the back and you dissect down, and with that high-speed burr, you basically shave some of the bone from the top, some from the bottom, and that takes away that area that has become thickened with bone spurs and thickened joint capsule to decompress those nerve roots. The problem with going through the back of the neck is when you go through the back, you have to strip muscle off of the spine. It's a longer incision, there's more blood loss, and there's a higher risk of infection. The back of the neck is a much sweatier place than the front of the neck. But each one has its own kind of inherent complications. So it doesn't matter if you go through the front or the back. All patients, especially if they smoke or they have diabetes or they're malnourished, they're at risk for what's called pseudoarthrosis, when the bone doesn't heal, doesn't fuse completely. And this increases for the number of levels that you operate on. So if I do a single level ACDF, it's probably going to be 90 to 95% successful in having some sort of fusion. If we do multi-level fusions, like a 3 or 4 level ACDF, now you're looking at 70% success rate, or a 30% rate of pseudoarthrosis. And pseudoarthrosis can be symptomatic with neck pain, or they can be asymptomatic. Going through the front of the neck sets you up for the potential for a recurrent laryngeal nerve injury or a hypoglossal nerve injury. Both front and back approaches can lead to vascular injuries. The vertebral artery, which goes to the brain, if this was to get injured, this can lead to stroke, and this can also be fatal. I don't have this video, but they showed it at one of the conferences I was at of a surgeon who was operating who hit the vertebral artery. It was like, it's like you see in the cartoons when like someone hits a fire hydrant and something goes like to the roof. There's blood that squirted to the top of the OR ceiling. It's pretty impressive and extremely scary, I'm sure, for the surgeon. Dysphagia, I tell patients, is the most common thing and the thing to expect when they wake up from surgery. When you're going through the front of the neck, we're moving everything off to the side. A single level takes about an hour, 2 level takes about 2 hours or so. So everything's being retracted for a couple hours. So when it comes back, a lot of patients will have a sore throat or a little bit of hoarseness. So I usually start patients on a clear liquid diet, encourage them to drink a lot of ice water to help with the inflammation, help with the swelling. If they're staying in the hospital overnight, I usually give them IV Decadron to help with the swelling. Because the nice thing with going through the front of the neck is that the infection rate is a lot less. So I feel more comfortable for administering Decadron, not having to worry about the immunosuppression and the potential infection side effects. When you're going through the front of the spine, there's muscles on either side called the longus colli. And on top of the longus colli is the sympathetic chain. And if you stray too far laterally during your dissection, you injure that, you can get what's called Horner syndrome, which is basically a droopy eye, a change in the pupil, eye bulges out. So that's why we never dissect further than the longus colli. And then adjacent segment disease, we talked about that, 3% per year, and that occurs with fusion type operations. So that's all I have for slides. I do have videos if anyone's interested of a microdiscectomy, and then also I believe it's a disc replacement or an ACDF. It's something for the neck, but I can always play those if anyone's interested, or if we have questions, we can go right to that.
I haven't had anybody ask any questions yet. If you do have any questions, anyone who's listening, please hover at the bottom of your Zoom screen, click on the Q&A and type a question in for me. Christian, I did have one question for you. I have an elderly mother who has been told for years that she has lumbar stenosis, and she's been to numerous specialists. She's had steroid injections, and nothing works for any length of time. Her symptoms are worse when she's standing. I know that earlier you said a lot of people have relief when they're standing rather than when they're sitting or lying down. She has the opposite. Standing for any length of time, she has shooting pain down her legs, weakness, but as soon as she sits down, that goes away.
Yeah, so patients who have disc herniations are a little bit different than those who have spinal stenosis with neurogenic claudication. So patients with spinal stenosis with neurogenic claudication, which sounds like what you're talking about, those patients, when they stand or they walk, their back is going into extension. Mm-hmm. That causes a decrease in the diameter for the spinal canal. So that pinches those nerves going into the legs. Typically, patients will get relief if they stop and they sit down, or if they go grocery shopping, you always ask them, like, do you lean on the grocery cart? Because when you're leaning forward like that, you flex the spine and you open it up to take pressure off the nerves. Patients who have disc herniations are a little bit different. When you walk into the exam room for someone who has a acute disc herniation, they're very uncomfortable. They'll be changing position. They won't sit down because when you sit down, you're leaning forward. When you lean forward, you put more pressure on the front of the disc are in the front, so you lean forward, you're putting more pressure, and it's causing that pressure to change out the back where it pinches the nerves more. So patients will be very uncomfortable. They'll change position frequently. They typically prefer to stand or lean against the exam table.
Okay. Would you recommend surgery is there a surgery you can do for spinal stenosis that is reliable?
Yeah,
in an 81-year-old.
So I just operated on an 81-year-old who had spinal stenosis at L3-4. So we did a decompressive laminectomy where we took the lamin off in the back and then put pedicle screws and rods to hold everything in place to allow it to fuse. So depending on what her back looks like, there's a lot of different ways. And if you talk to 5 different spine surgeons, you'd probably get 5 different answers.
Yeah, and that's sort of what she's gotten is a bunch of different answers. So.
And it's all a matter of where people have trained. So some places are much more conservative. So I trained at Dartmouth, which is very conservative. Mm-hmm. There's other places in Texas or Florida, which are very aggressive. And every patient who walks in the door, gets surgery. Right. I trained somewhere kind of in between where we still valued the conservative measures, but we realized that a lot of patients will benefit from surgery. So it was kind of nice being trained at somewhere that's conservative, but somewhere that's also a little bit more progressive. but even like among my other partners where we've trained at different places. So Dr. Murphy trained at New England Baptist, Dr. Wilkening trained at Johns Hopkins. So even though like Wilkening and I trained the same exact year, we do things a little bit differently just because we had different mentors, and those different mentors trained different places. So you pick up little tidbits here and there, which is kind of the fun part of medicine, where you work with one attending and you like the way that they did their physical exam, so you start using that. You like another attending's way of doing a history, so you use that. You like someone's positioning or someone's draping, or you like to curette someone. So you get to pick up all these little things and you develop your own practice. So that's why UOC five people will get five somewhat different answers, because the main thing is doing what you're comfortable with.
Yeah, good. Let's see, I do have a question from Beth. Actually, I have a couple of questions from Donna. What do you prescribe for inflammation in a patient who takes blood thinners?
So usually I'll prescribe a like a prednisone taper. I like a Medrol dose pack. Those patients who are on blood thinners, they can't get the high dose NSAIDs because it will affect their coagulation. So I usually prescribe a Medrol dose pack, short 6-day taper.
Okay. And go ahead.
I was gonna say, if someone has diabetes that's not well controlled, I won't prescribe that, and I'll try other things, lidocaine patches. I'll try gabapentin if they're having leg pain. Try muscle relaxers, Voltaren gel. There's a lot less systemic absorption. That's something that can also help.
Okay. Another question: what area in the back causes nerve pain from the pubic area to the knee in the inner upper thigh, and no position gives relief?
So the pain that radiates kind of from the groin to the inner thigh is higher up. So S1 usually goes straight down the back. L5 usually goes down the back, wraps around to the front. L4 usually wraps around the front down to the inner part of the ankle. The lady we just operated on today, she's having L3 pain, so that's going from the buttocks, wrapping around the front of the leg to the inside of the knee. Then you get even higher than that, so L2, L1, that's usually groin pain that radiates into the inside of the leg. It's usually L1 or L2.
So it sounds like that's the area that she was asking about. Another question: since the disc replacement surgery is newer, is it being approved by most insurance companies?
It is, because there's a lot of data and a lot of research that backs it up. They've done studies in Europe for, I want to say, 15 or 20 years. Same thing in the US, 10-year follow-up looking at reduced rates of adjacent segment degeneration. The place where I trained, Ortho Carolina, did a lot of those studies, so we did a lot of them down there. So it's again, it depends if you're doing surgery for the right reason. You always have to pick the right patient, do the right procedure at the right time, and when you have that, when everything lines up, it's a very good operation, and insurance companies have started responding well to that, and they I haven't had any issues getting those approved.
Good. Do we have any other questions? I don't see any coming in. I want to thank you for doing this talk, Christian. This has been great. And reminder to everybody who's listening to complete your evaluation.